Good morning, everyone, and thank you to all the organizers for the opportunity to talk about diabetes epidemiology and management of risk factors related to diabetes. So my disclosures have received funding from the National Institutes of Health. I've also received funding from Mayo Clinic for work on diabetes and disparities. And I've also received some funding from Dalio Philanthropies through Mayo Clinic and also some unrelated book royalties. So right now, as was shared earlier, I'm a physician, I'm a hospitalist at Mayo Clinic in Rochester. Most of my time is spent on research, and I do a lot of work on diabetes and chronic diseases. So we look at premature heart disease and stroke. And the rest of my time is also spent in providing care to patients in the hospital. A lot of the research that I do is based on observational studies, and we also develop clinical trials to try and improve outcomes for diabetes. Most of the work is related to disparities based on race, region within the United States. We know there are a lot of differences based on where people live. And in particular, we're also looking at rural-urban disparities, because I think there's more information now that where people live, whether it's a rural or an urban area, they may be more likely to have some disparities. And separate from that, I also work with the Olmsted County, which is our county where Mayo Clinic is based, as well as the Minnesota State Department of Health on some of their advisory committees related to health and human services. So our objectives today will be to talk about the epidemiology of type 2 diabetes, and we'll talk about it briefly in the global context, some work in the US and then in India. We'll also discuss some of the risk factors for type 2 diabetes and review some strategies to manage risk factors for diabetes. There are many presentations today and tomorrow that will talk a lot more about many of these topics, so I'll keep it at a slightly high level for the risk factors. So internationally, the global burden of disease has been a very important collaboration to understand the burden of diseases, injuries, and risk factors. And this collaborative has over 1,000 investigators, and it's based at the University of Washington in Seattle. Over the last several years, they have generated estimates for many conditions, and they've done this at a global level. They've also done it for each country, and more recently, they have started to look at subnational estimates because they realize that there are disparities subnationally. Recently, the Global Burden of Disease reported on the burden of diabetes, and this was in their publication last year. They looked at the burden of disease from 1990 through 2021, so that's almost 30 years. And then they went on to project the burden of diabetes over the next 20 years. This was a very big collaborative. If you look at their Lancet paper, they have about 4 pages of just collaborators. So they've used 27,000 data sources to generate these estimates. And this is based on 204 countries and territories, and they focused on adults 25 years and older. Based on their estimates, 529 million people worldwide have diabetes. They couldn't always separate type 1 from type 2, but it's a very high burden, given that the population of adults in this age range may be about 6 to 6.5 billion. They have provided estimates looking at a number of different parts of the world. And if you look at the prevalence map here, which is shown in light, it's less than 4%, so 4 out of 100. And the darker the color gets, the more diabetes is present. So in the very dark ones, in the dark red, it's 18 to 30 to almost 30 people per 100 that have diabetes. When they looked at different regions of the world, the highest age standardized rates were present in North Africa and the Middle East. And specifically, even within that, Qatar had the highest age-specific prevalence. So if you take people aged 75 to 79, almost 75% of the people have diabetes. And then they've looked at other regions of the world. So here, if you look at the x-axis, it's starting with ages from under 5 to 9 years, all the way to over 95 years of age. On the y-axis, they have the prevalence rate, so that's the number of people with diabetes out of 100 people. And then they looked at different regions. So they have Central Europe, Eastern Europe, they have Latin America and the Caribbean, North Africa and Middle East, South Asia, Southeast Asia, and Sub-Saharan Africa. And one thing that you see in the younger ages, whether you look at maybe the age of, say, 10 to 14 up to about 25 to 29, most of the regions have similar, roughly similar prevalence, but you can see for all of them, the prevalence is going up a bit. And then when you get to the age of about 35 to 39, that's here, you see a bit of divergence, and then that expands quite a bit as you go to the older ages. And this bar here relates to North Africa and the Middle East. So in all ages, in all countries or regions, the burden of diabetes increases with age, but even within that, there are a lot of disparities based on different regions. And these are estimates from 1990 to 2021. And if you look at what they've projected for the next 30 years, that's more worrisome, because overall, you have type 2 diabetes globally, so that's about 2.5 per 100, and over the next 20 years, it's going to go at least 3 or 4 times that. That's type 2 diabetes. You almost don't see type 1 diabetes on the graph because it's right at the bottom here. It's estimated to stay roughly flat, but the type 2 diabetes is expected to increase significantly over the next 20 years. And for a lot of people who think about type 2 diabetes, we know there are some genetic factors, there are hereditary factors, but we know a large part of it is related to lifestyle. So part of this increase in prevalence for type 2, but not type 1, may also be a reflection of how people's lifestyle and habits are changing. If we start to look at different countries, there's no country that is spared from the burden of diabetes. In the United States, this is some of the graph that I've shown is from 2017, but the other estimates are from about 3 years ago. If you look at different parts of the US, so here under 9%, that's the lowest burden. So you have maybe some states here, this is Minnesota, this is where most of us are from, and then you have some other states here in the West. But if you go to the deep south, there's a very high burden of diabetes. And if you look at the adults in the US, there are about 320 million adults. 97 million have prediabetes, and we know that many of them are going to go on to develop diabetes. 37 million already have diabetes, but there's also a problem of underdiagnosis. So many people have diabetes and don't know. So we actually think it's probably higher than 37 million adults. And there is a huge human cost, because when people have diabetes, there's an impact on them as well as their family members. But if you also look at the financial cost, it was 413 billion in 2022. And that was 26% higher than what it was 5 years ago. So this cost is only going to continue to increase. So there's a human cost, there's a healthcare system cost, there's a family cost, and there's a community cost. From this, it's not easy to appreciate how much the diabetes burden has changed. But if you look at, this is the US in 2000, they looked at adults 18 years or older. These are data from the US Centers for Disease Control and Prevention, or the CDC. The lightest blue is 4.3 to 6.5%, so that's about 4 or 5 people per 100. And then the very dark one goes from 11 to about 17. And there are some areas for which we don't have data. That's in 2000, to almost 25 years ago. And then you go to 2010, the map starts to get darker. And then you get to 2020, and it's very dark. Most of the United States, the prevalence of diabetes is about 9%, because you can see there's mostly dark blue and very dark blue. And there are very, very few states, if any, that have a very low percentage or prevalence of diabetes. And again, we always say diagnosed diabetes because there's a big problem in the US and other places of underdiagnosis. People are not regularly screened. People might not know that they have diabetes, but are probably living with it for several years. Closer to where we are, there was a very nice effort from 2008 to 2020, and Dr. Joshi is also part of the collaboration. And this is from ICMR, the Indian Council of Medical Research, and the India Diabetes Study. And this was a heroic effort from a cross-sectional perspective and population-based for a 12-year period. And they wanted to understand the burden of diabetes in India. So this is just looking at it overall. The color scheme is provided here. The green ones have about 0 to 5%, and all the way to the red, which shows over 10%, so over 10 per 100. And you can see there are many states in India that are either pink or red, which means there's a high burden of diabetes. So as part of this study, they surveyed over 100,000 adults that were over 20 years of age, and importantly, they sampled people from rural and urban areas. If people already said they had diabetes, then they just got a fasting glucose. If people said they did not have diabetes or were not aware, then the study looked at fasting glucose and 2-hour oral glucose tolerance test. And based on this, 101 million people were estimated to have diabetes, so it's 11 out of 100 people in India that have diabetes. And this is much higher than was previously estimated. The diabetes burden was higher in urban areas, and 136 million people were estimated to have prediabetes. And this is problematic because we know that many people who have prediabetes go on to develop diabetes. There are cases where people can change their lifestyle. We'll talk a little about that. We'll talk about that briefly. So people can go from prediabetes to having a normal glucose profile. But the more common scenario is that people will go from prediabetes to diabetes. And this prevalence is about 15% in India. The prediabetes burden was estimated to be higher in rural compared to urban areas. So one of the questions that comes up is if we want to try and reverse some of these trends or want to improve the burden of diabetes, how do we do it? And so that's when we start to think about risk factors. And this is from the same study from the ICMR India Diabetes Study. They looked at a number of different risk factors that are typically associated with diabetes. And we already talked about diabetes and prediabetes, so we can skip that for a second. And if you look at some of the other risk factors, abdominal obesity was the highest, estimated 350 million people. And then you can look at generalized obesity. That's 250 million people. There's probably some overlap between the two groups. Hypertension, 315 million people. So a lot of people with a high burden of risk factors. So if we start to look at some of the risk factors, and obesity is always, when everyone talks about diabetes, the first thing they think of is obesity. So here they used a cutoff of 25 to define obesity, which is appropriate because in a lot of other studies they tend to use a BMI of 30. But if you look at race and region, 25 would be a more appropriate cutoff. Or abdominal obesity, which just takes into account the waist circumference, different cut points for men and women, which is also appropriate based on other studies. So again, there's a very high burden of obesity, and it's distributed fairly uniformly throughout the country, but there appears to be a higher burden in the southern parts and then maybe some parts even in northern India. So if we start to look at managing obesity, there's still a lot of controversy about what we should follow. Should we go based on body mass index? We know there are a number of problems with that, but that's the most well-known and common metric that's been used. Should we use waist circumference? But where do we measure waist circumference? There's a lot of variability in how people measure it. And then there are two related ones, waist to hip ratio and waist to height ratio. And there are very few studies that have compared all of them head to head to see which one is better. But these are the four metrics that people tend to use to quantify obesity. What we do know, regardless of what method you use, if you lose weight, so that's about 3% to 7% loss of body weight, you can improve your glycemic profile. If you are able to have at least a greater than 10% loss, there's an improvement in cardiovascular and mortality benefit. But it's fairly easier to lose weight, but very difficult to sustain that weight loss. So a lot of people who lose weight, even over an 8 to 12 month period, tend to have rebound obesity, so they tend to regain all of that weight. So it's not sufficient to only lose weight, but it's important to try and sustain that weight loss. More recently, there's a concept of remission of type 2, and people have said, is it possible that if we just lose a certain amount of weight and do things, we can come off all medications? So there are a few papers that have talked about remission of type 2, but it's not as well understood as everything else is. Related to obesity, it's very difficult to think about obesity and not talk about nutrition, physical activity, and behavioral therapy. And there are a number of programs that have started to look at lifestyle choice, and they want this to be structured. Sometimes you see people who rapidly lose weight and then equally rapidly gain weight. So all of this should be in a more structured way, ideally through the support of programs. So aim for about 500 to 700 deficit per day. It's easy to tell people to lose weight, but many people have restricted access to healthy food, so it's difficult. If people cannot afford to eat healthy food or benefit from counseling or programs, they're not going to do it. If people have large families and they need to provide for all of them, they're not going to worry about their weight loss. And more recently, there has been a lot of talk about caloric restriction versus intermittent fasting. Intermittent fasting has sort of been the new way of losing weight and improving your metabolic health. And there are different ways in which someone can engage in intermittent fasting, but in some cases people say you should restrict your eating to about 8 or 12 hours per day. So you're not eating for about 16 hours. We don't know all the benefits of this, but more recently there have been some studies that have also showed that there is increased mortality or cardiovascular related mortality from intermittent fasting. So we don't know if intermittent fasting, we don't have large randomized clinical trials. We have few small studies that showed intermittent fasting may be beneficial, but more recently there were some conference presentations that show that there may be a high risk of mortality. So I think we need to understand what is the advantage of caloric restriction, what is the way to conduct intermittent fasting, if that is correct. Is it 8 hours, is it 12 hours, does it matter when you do it, and try and compare intermittent fasting with caloric restriction. And then there is a lot of discussion about medication for weight loss. If you attend some of the conferences, particularly the American Diabetes Association conferences a few years ago, everyone talked more about lifestyle and other things, and now if you go to the conferences, it's mostly about weight loss drugs. But there are a lot of other experts who are going to talk about it, so I'm going to skip that topic, but it's definitely gained a lot of attention in the last several months. Another important risk factor to look at is hypertension, and this is a major risk factor for diabetes. And here, this is again from the ICMR study, they used cutoffs of 140/90 or use of antihypertension medications. And this was appropriate, it was done from 2008 to 2020, but an interesting question to ask is what would happen if we use the more recent cutoffs of 130/80? What would happen to the burden of diabetes, of hypertension, and what does it mean for diabetes? There are many strategies to manage hypertension, comes back again to dietary strategies, lifestyle, and medication. And there have been some small case reports where people have talked about curing hypertension. So people can be on therapy for a period of time and then not require any therapy and remain free of high blood pressure. But that, again, there are very small studies on that. Recently, the ACC, the American College of Cardiology, and the AHA, as well as the European guidelines, the European Society for Cardiology, they harmonize their recommendations because it's very confusing. You can live in one part of the world and you have certain recommendations, and you go to a different part of the world and you have different recommendations. And so here they've harmonized the management of hypertension, a lot of it related to lifestyle, following a certain diet, weight loss if appropriate and if possible, and tobacco cessation. So very briefly, there are a few frameworks to reduce risk factors because it's not as easy to tell someone to lose weight, reduce your blood pressure, and eat better. So we need to look at a few of the risk factors. Now I'll talk about this very briefly and a little more in detail in the afternoon when we talk about research. But this was in the United States where they were charged by the US Congress to make recommendations. And they looked at this from a population level, high-risk individual level, as well as the individual level. And they came up with 39 recommendations. I won't go through all of this, but this just shows how complex it is to try and affect diabetes. It's not going to be as simple as telling an individual to do this. There are individual factors, societal factors, behavioral factors, and healthcare factors. All of this also being affected by government and public policy. And so here they've also outlined strategies for prevention and management. And I bring this up not so that in India they can mimic what was done in the US, but to also have a more comprehensive approach and think about how it can be done in India. And very recently, the Union Minister of State for Science and Technology launched a rural health program, and at that time they talked about prevention of diabetes being a priority. And they know that a large number of people, almost 70% of the population, is under the age of 40, and they're all going to be prime citizens as they think about a 2047 vision, which is 100 years after independence for India. And they talk about ideology, precision medicine, all the way to health policy. So in summary, in India, over 100 million people have diabetes, and it's much higher than was previously estimated, and these data come from the ICMR study. There's a very high prevalence of risk factors, such as obesity, hypertension, and other ones such as dyslipidemia. Diabetes is a major risk factor for morbidity, amputation, vision loss, cardiovascular disease, as well as mortality. And it may not be sufficient to focus on the individual level, and we may have to think about individual, household, and community level interventions to reduce the burden of diabetes.
Thanks.
With that, thank you.